I'm Stan Appel. I head the Department of Neurology at Methodist Neurological Institute, and I'm also director of the MDA ALS clinic there. Well, I think the key issue is when you tell someone that their cognitive function might be impaired, you're really talking about memory and a lot of difficulties along those lines. And our ALS patients don't have a memory problem. What they do have a problem with is they think a little bit more slowly than they used to, and we call that executive dysfunction. So the memory functions are usually the back part of the brain, and those are relatively preserved in our ALS patients. But what is involved in almost 50% of the patients are some of the frontal difficulties, and we call that executive dysfunction, or specifically frontal subcortical dysfunction. Now that's a very important difference because these patients don't have Alzheimer's disease. They don't have anything like Alzheimer's disease. But the impact is critical because what it now tells us is we're constantly telling the patients, look, we're worried about you falling. We're worried about your choking. We're worried about your breathing. And we want them to do something about it, and we have proposals that let them improve these functions. But if they're a little bit slower on the uptake and a little bit more stubborn and in fact have this kind of difficulty understanding the impact of this, then they're not going to listen. And then we have to convince the family. But you know what the family tells us? They say, you know, my loved one is not the same person, and he doesn't seem to understand. He's a lot more stubborn about things. I have to say things 5 times over. He's not thinking as quickly as he did before. His memory is intact, and he can solve puzzles like he did before, but it's a little bit different now. And he doesn't want to listen to me, and he doesn't want to do the things that you're suggesting. So we need to work with our patients, and this is extremely important. Now, this is in the usual sporadic case of ALS we're talking about. But what we've learned is when there's something running in the family, as there may be in 10% of the cases of ALS, then there's an overlap. Some family members with ALS may have no difficulty with frontal function, where others may have a frontal difficulty that we call FTD, frontal temporal dementia. And what is happening is these two distinct disorders, FTD and ALS, are merging, and we understand there's tremendous overlap. And this is the major thing that's changed as we approach ALS. But even in the sporadic ALS patients, we're obviously beginning to see this interaction, which has an impact on clinical care and what you tell your patients.
Thank you.